Welcome back to Your Mouth Matters. Today, we have an incredible conversation lined up with a true innovator in the field of periodontal therapy. Joining us is Judy Carroll, founder of Periopeak Innovations and the developer of the Regenerative Periodontal Endoscopy, RPE protocol. Her approach to treating advanced gum disease has changed the game, and a key part of her method involves a surprising tool, doxycycline. But here's the twist. It's not just about killing bacteria. We'll be diving into how doxycycline works as a host-modulating therapy, why it's essential for tissue regeneration, and what patients need to know about its benefits and considerations. If you're looking for cutting-edge solutions to gum disease treatment, you will not want to miss this episode. All right, well, welcome, Judy. Thanks so much for coming on the show.
Thank you, Dr. Taylor. Thanks for inviting me. I really appreciate it. I don't get to do many podcasts, so I'm really grateful to be here. Thank you.
I just am you've been such a mentor for me. So if you don't know, Judy's actually my aunt, but she really has been inspiring to me. I remember in dental school, I had a friend and, he's like, oh yeah, we'll just do as many cavities and, get all this money and whatever. And I'm like, hey, I kind of just want to I want to treat people like their disease and figure out the why behind things. And it was so interesting in dental school because it's just not really something that's talked about at all. Let's figure out the why and figure out what, the host is doing and how they're responding to treatment. And so when Judy was doing this type of hygiene and I was exposed to that, I was like, well, that just makes so much sense. So she's been a really big mentor for me and really taught me a lot. So can you tell us, Judy, about your journey and how you developed RPE and just tell us a little bit about you and your history.
Yeah, I'd love to. Okay, so I've been a dental hygienist for 35 years now, going on 35 years. The first 10 years I practiced in general practice and full mouth rehab, cosmetic practices, and took a lot of laser courses and a lot of, more advanced perio courses with LVI and places like that. And I ended up, while I was doing all that education, about 10 years into my profession, I ended up working for a periodontist in Seattle. And, when you go from general practice to a perio office, oh my gosh, it's a whole nother world. You're dealing with end stage disease, really severe stuff. And every day I was watching people get all of their teeth extracted, pretty much every week. I'm watching full mouth extractions occur or multiple extractions and, full mouth surgery, a lot of osseous surgery, very surgical practice. So, one day this 27-year-old young man who is about the age of my son currently come in and had all of his beautiful teeth extracted. And it was really a very profound, I would say, moment of clarity for me, kind of a turning point. I was it made me so depressed and angry at the same time to see this young man's teeth all laid out on the towel, getting ready to go through the sterilizer. He had these beautiful teeth. There wasn't a single cavity in his head, by the way, not a single cavity, just beautiful teeth. And he lost all his teeth that day to chronic periodontitis, aggressive periodontitis. And I decided that day that I was either going to leave the dental field entirely, or especially dental hygiene, because I felt so helpless, or I was going to find a solution. And so I complained to my periodontist. I did that quite frequently, by the way. We went hiking together a lot. So I would kind of bitch and moan and complain to him a lot that, doing blind root planing was a ridiculous procedure. And I wanted to do better because I wanted to do better by the patients. And I didn't want to see people go through surgery and have all their teeth extracted, or even having multiple extractions and full mouth osseous. If you've ever assisted a periodontist doing osseous surgery, and if you've never assisted, you really need to get an eye-opening experience about how aggressive and traumatic it is, right? And all of that experience culminated in, like I said, me complaining to my periodontist, and he went to the AAP conference in Hawaii in 2000 and ended up bringing back the first generation dental endoscope. Actually, it was the prototype endoscope. There was only 10 of them made. And he brought it home for me. He goes, "You won't believe what I got you. You're going to be so happy." And I was just doing backflips. I couldn't sleep for 2 weeks when he told me what was going to be delivered to the office. So he told me, and this was a great experience because he told me I could do whatever I wanted. He said, I had 2 different lasers. I had access to every technology, every current technology, including regenerative proteins, right there under the supervision of a periodontist to come up with a protocol that would get us terrific results. We really wanted great results. We wanted long-term results, right? It took me a few years to really come up with this recipe, and that's what I call regenerative periodontal endoscopy. It was a long road of failures and successes, but when you do hundreds of cases, back then I was working 5 or 6 days a week as a specialist. I was just doing nothing but these cases in 2 or 3 different offices. And you get to observe results, right? And what you want to see is long-term results, but you also want to see results with very challenging host factors like smoking, diabetes. Especially in a perio office, you see a lot of really challenging risk factors. So I wanted to develop something that would work for everybody, no matter what their risk factors were. And my very first case was this gentleman. One of my very first cases was this gentleman with full-blown AIDS. And, back then it was quite different. This was back in 2000. And, this guy was going to lose his life and he was going to lose all his teeth. He's either going to lose all his teeth beforehand or lose his life. He came to me with ANUG, like really bad, acute necrotizing ulcerative gingivitis. And I talked to my periodontist and I called his specialist, the patient specialist, and I said, hey, we want to do this protocol. And back then, it was the early beginning of using doxycycline. This is why I'm bringing this up. We want to give the patient periostat, doxycycline, low dose, and this is with his specialist, his medical specialist. And we'll use some antimicrobials like iodine, and we'll also use an endoscope. But we really want to help because helping his perio obviously is going to help his overall immune system.
Can you talk about what is the endoscope?
Oh, so I'm sorry. The dental endoscope, as part of the RPE protocol, the periodontal endoscope is miniature fiber optic camera that we can actually place under the gums without having to cut. So we just go into those deep pockets. And this gentleman had plenty of deep pockets for me to go in and remove all the toxic calculus or tartar that's trapped under there that we can't reach. We can't see or feel it when you start to develop pockets over 5 millimeters. You really can't do a good job at getting all that toxic stuff out of there. And to achieve healing, you really need to remove the toxic calculus. And so there's been a lot of studies on that. We now know that we've really got to get that off. Otherwise, there's still a chronic inflammatory process going on. So yeah, that was my introduction, was to use an endoscope and doxycycline for this patient that was really about to lose all of his teeth. And so when I saw the profound result on that patient, it just sort of catapulted me in that direction of using host modulation, what we call doxycycline, low dose doxycycline, and the endoscope to treat really severe cases. And then very shortly after that, we got a terrific result. You should see the photos on this patient. I didn't take before photos because that was before I learned photography, but now I document all my cases very carefully with before and after photos. But I have the after photos on him. His name's Randy. We saved his life. We saved his life. And had we not intervened, I just don't, I think it would have gone in a pretty bad direction. And his medical doctor understood that. So, you and I are going to be talking about this, the need for periodontal medicine, basically. You can't just do basically root planing and maybe kill the bacteria with either an antibiotic or lasers or ozone. You have to also treat the host response, because in Randy's case, his immune response was really needing that help. And that's what we can give our patients, is this 2-pronged approach where you're not only doing the topical removal of the bacteria and the toxic calculus, but you're also doing a systemic approach where you're lowering inflammation in the host enough to where that now they can resolve, it's about resolving chronic inflammation.
Yeah.
And the host, especially that patient, was completely unable to resolve inflammation. And so he was quite a rapidly progressive case that would have lost his teeth real quickly. And and by the way, those cases have become my specialty. But it took me, and I'm very successful, by the way, doing that, because when you incorporate host modulated therapy and doxycycline, low dose doxycycline, and you're using it on severe cases, you can treat patients, with an endoscope that are, they have bone loss all the way to the apex, all the way to the apex of the root. So 15, 16 millimeter pockets routinely. I treat patients with, and those are actually my favorite cases because they're so severe that you get to see just how incredible this protocol, what we can actually achieve if the host is given what it needs to heal, and you also remove the toxins. So you remove the offensive stuff and you give that host something that promotes rapid healing of those pockets. And we're going to talk about the third part of this protocol, which is the regenerative proteins. And back then on Randy, I wasn't using regenerative proteins, but later on I would discover that in my protocol because I was trying all sorts of different things. I was trying lasers and all sorts of different things. And when I added Emdogain, a regenerative protein, it's a signaling molecule that tells your body's own stem cells to come into the area wherever we place it in the deep pockets. And it just signals the stem cells, your body's own stem cells, to come to the area, proliferate there, turn into regenerative cells, and we regenerate cementum, periodontal ligament, and bone. And then when you add Emdogain with the periostat, the low-dose doxycycline, what you get is you get this synergistic healing. It's so rapid. It's so incredible because both the Emdogain and the periostat, the doxycycline, are anti-inflammatories, and both of them promote regeneration. Mm-hmm. So you've got a systemic medication and you've got a topical protein that you're placing, a gel in the pocket that stays there for a month, by the way, and continues to signal the stem cells to come to the area for a whole month. And while that patient's taking doxycycline, 20 milligram doxycycline, you're getting this synergistic regenerative effect because they're both anti-inflammatory, and actually the Emdogain is antimicrobial. So you're keeping any pathogens out of that pocket, for a month. It's creating this beautiful healing effect. But also the doxycycline oxygenates the pocket. So you're getting an antimicrobial effect from the doxycycline simply because it's creating a more oxygenated environment. The host is now, you're kind of balancing out this hyperinflammatory immune response, and you're bringing it down to a nice even keel. And it's in that homeostasis that's what you're trying to achieve, is homeostasis. You're bringing that inflammatory response back to normal, which is what periostat does. And once you do that, then once you've achieved homeostasis, then you can regenerate tissue and bone. So it's actually regenerative because it activates the body's bone building cells and the tissue building cells. So it activates fibroblasts and osteoblast cells along with your Emdogain. So they work synergistically. It's a beautiful thing. It took me a long time to discover it.
It's a perfect
you have
recipe.
to use an endoscope, because if you don't use an endoscope and remove all those toxins, you're still going to have chronic inflammation. You just are. And the only way for you to understand this is to take an endoscope and look into your patient's deep pockets, even the ones that you're trying to maintain. Yep. All you got to do is look with an endoscope and realize what your protocol is either doing or not doing. It's very much a teaching experience, a very humbling teaching experience to use an endoscope. So that's RPE in a nutshell. I'm sorry, I kind of bunny trail a little bit, but
no, you're fine.
But it took a long time to figure it out. It took about, to be honest with you, it took like 3 or 4 years of doing a lot of cases, and then also dialing in when to start the low dose doxycycline on a case. Yeah. So I discovered that putting them on the doxycycline before I started therapy, which I didn't know back when I treated Randy. Periostat, this medication called low-dose doxycycline, it was FDA approved for putting the patient on it the day you start therapy, root planing. And that kind of protocol never really made sense to me. So I started putting them on it 2 weeks before. So I would get this anti-inflammatory effect before I would start my endoscope therapy. And The difference was night and day. It was night and day. I could actually see more clearly with my endoscope. It reduced the bleeding and the granulomatous tissue so much that now I could see. And if you can't see with a dental endoscope, right? Again, it goes back to if you can't see, you can't remove that toxic stuff. But it also reduced the bleeding so much so that when I put the regenerative protein in there, I wasn't competing for the blood protein getting on there and interfering with what I was trying to do with bonding that protein to the root, getting that. So and also then getting rapid healing after. So 2 weeks before I discovered, and then as I got deeper into the science, it was like, oh my gosh, you reduce the harmful levels of collagenase, which is a destructive enzyme, by 60 to 80% in only 2 weeks' time. So it's kind of interesting because that was what I observed with my endoscope was this significant reduction of inflammation in only 2 weeks. And then I discovered in the literature that was exactly, kind of the sweet spot, if you will. You get a reduction of inflammation before you start doing your therapy, whatever it is, root planing with a laser, whatever it is that you like to do, or even surgery. And you're going to get that lower level of collagenase. So you kind of already started this host in a healing response. And what's really cool about that is they don't have postoperative sensitivity.
Mm-hmm.
They're not going to have postoperative pain and sensitivity. And because all my patients travel in from out of country and out of state, that was a big deal for me. I couldn't have patients have problems, Postoperative pain and sensitivity is something that a lot of people report after they have traditional root planing, deep scaling. And when I discovered this three-pronged approach, which helped me create a much more rapid healing response, that was really the key. That was so key because especially the deeper the pockets, if you don't get those pockets to close right away, and I'm talking about within a day, because the doxycycline is already doing this. I call it the invisible suture effect, if you will. It kind of cinches those gums up around the neck of the tooth, but it's also keeping that emdogain in there, right? That protein in there. And I tell my patients, and I teach this when I lecture, I tell people, this is the most beautiful protocol. All you got to do is think about the science. I mean, just think about that. If you understand periodontal pathogenesis and you really begin to understand each one of these three technologies, it's just a beautiful, because it creates such a rapid healing effect.
Yeah.
Whereas if you left one out, it's not going to have that magic. It's kind of like, if you've got a recipe like Coca-Cola or Kentucky Fried Chicken, you leave something out of that recipe, it's not going to be the same.
Exactly.
That's probably not a good
and
analogy.
I feel like this is such a great conversation to have because like so many patients that we see, they come in and, you start talking about the protocol and the three-prong and like there's, the doxy and the emdogain and then this, and they kind of want to cherry pick. Like a lot of patients are like, well, do I need to have the emdogain or do I I don't really want to take a pill. I don't really want to take the doxy. And I just feel like I'm kind of like a parrot. Like I'm just having this conversation over and over. I'm like, no, this is where the magic happens. It really is a recipe, right? And so if we leave something out, you're not going to get the results, And I've had the privilege of working with Judy and seeing her patients. I remember one person came in and their front tooth was so wiggly, I felt like I could probably have taken it out with my fingers. I mean, so much mobility in this front tooth. And you were like, well, I'm going to treat it. We'll see what happens. He came back a couple months later. That tooth was rock solid. I mean, I was amazed because like you said, you go to the periodontist, you go to the dentist and they're like, oh, that tooth is hopeless. We can't save that tooth, right? So, and it's amazing that you've developed a protocol that is so effective. Now, you can't save 100% of teeth, but if you're treating teeth that people normally would say, there is no way you can save that tooth. And it's because you're using that recipe, right? So if you're listening and you've heard of root planing or scaling root planing or deep cleaning, that's the other thing that dentists call it. So that's when basically the dentists, usually they get you numb and then they go under the gums and they're just kind of blindly scaling. And the problem is that they're leaving behind a lot of that calculus that Judy was talking about. how much calculus? I mean, I know there's studies that
50 to 60%, really. To be honest with you, I've seen more.
Yeah. So if you don't
And it's only
remove,
because when I mean, how good would you be at prepping a crown with a blindfold on?
yeah,
It would be
blind.
terrible. You wouldn't
Yeah.
be very good.
Yeah.
So it's a very limiting thing to be, scraping around under the gums. The science is pretty clear on that.
Yeah.
It's,
You
the
have to
Onadil,
remove the calculus. And the problem with the
yeah,
traditional methods is that we know that 60% is left untouched, right? And so how are you going to
yeah.
heal? It's kind of like having a rock in your shoe, right? Like you got 10 rocks in your shoe. You remove 4 of them. Well, guess what? You still have rocks in your shoe, It's like your foot's going to hurt. You're not going to be able to hike up the mountain with, 6 rocks in your shoe. You have to remove them all, Or it's like trying to glue 2 things together, but having gluing 2 pieces of wood together, but having a ton of dirt on the wood, like that is not going to stick. You have to clean the surface first, right? So if you're not using the endoscope to go under the gums so you can see the microscopic calculus, right? The microscopic calculus is what houses the bacteria. If you're not doing that piece, then you're missing a huge part of this, right? And the other things like the doxycycline and the Emdogain that you put under the gum to recruit the stem cells, those things are not going to work because you cannot glue the 2 pieces of wood together if there's a bunch of dirt, right? So that's why I think the endoscope is just so important. And it's like, it gives hygienists eyes. You can actually see what you're doing. And you can, and I mean, like, you see all sorts of crazy stuff. I mean, we had a patient that had braces on when he was 15 and his gums looked great. And there was one pocket that just didn't heal. And he had been in to see our hygienist, every 4 months, like just religiously, and this pocket just didn't change. And like, take a camera down there and there's this big chunk of orthodontic cement that's been there since he was 15 years old, and like this guy would have lost that tooth.
I treat probably at least 2 or 3 a month like that. There's a lot of those cases out there.
Yeah.
And it's not just one area with a lot of them. It's all the molars.
Yeah. Well, yeah, because if you have braces,
it really
cement.
sets them up for a lot of chronic perio issues.
Yeah. So that's kind of like.
So anyone who's had full bands, they should really visit someone who's good with an endoscope to get that off if they have any inflammation.
Yeah.
Because the orthodontist and the assistants can't remove that stuff. They're not using an endoscope, right?
Yeah.
And that's why really an endoscope should be an ortho op. Well, they don't do, I don't know how many are doing full bands anymore. Do they still do that?
They don't do full bands anymore. But but they're doing full mouth reconstruction. You're getting crowns. They're seated some digitally. So, I mean, I think.
Yeah, we used to, in my cosmetic office, we would take full mouth rehab cases and I would go through and be the one to fine tune them after they got all the bonding done.
Yeah, that's amazing.
That's how much we believed in the ability to keep patients healthy and remove all that bond. And, because if you want a nice smooth margin, if you want that restoration to last a long time. But yeah, using an endoscope is a very humbling experience, but it's really honestly the most fascinating thing that a clinician could have in his or her hand because there's never a dull moment. I'm never bored. I've been doing this for 25 years this year and I'm still excited.
Yeah. Well, you find also, it's like scuba diving,
I was telling my patient on Friday, I feel like a scuba diver every time I go in here. I feel like a scuba diver because I'm working in class 2 and 3 furcations all the time. And I'm in 15 millimeter pockets routinely. And the things that I find, and I mean, it's just a whole nother world down there, Yeah. And I want to mention one other thing. I think this is very important to mention. When you pick up an endoscope, it's not just that you're now able to diagnose things like root fractures and decay, recurrent decay, and remove calculus. There's all of that diagnostic stuff. But it's really teaching you to be a much better clinician because, the probing that we do to measure your pockets, if there's patients listening, we're using this probe to measure your pockets and it doesn't feel very good, that procedure. Most of those probing depths are inaccurate.
Yeah. Well, in this guy's case.
And you don't find that out until you pick up an endoscope on a daily basis.
Yeah, because in that case I was telling about, like that pocket was a 5 millimeter. And then when we went in there,
It
we
was like a
like saw that
15.
there was cement. We broke it off, and then it was a 15 millimeter pocket with pus coming out. So yeah, that the
Yeah,
probings
that
weren't
was,
accurate at all.
yeah.
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 So, but
I was there that day.
I know you were. I know you were. Yeah. But anyways, it's like, I love that. So the endoscope is an important tool, but the other thing that's so key, and I feel like this is so missed in the dental world, like completely missed, is the host modulated response. Because
Yeah.
you can have, I always tell patients, like, if I get a mosquito bite and my husband gets a mosquito bite, my arm swells up. It's super itchy. It's like a welt. It takes like 2 weeks for it to go away. It bruises. It's like an insane reaction to a mosquito. And like the same mosquito will bite him and it's like a tiny little dot. It doesn't itch at all and it's gone the next day. And it's like, how can we both have the exact same thing, but my reaction is so much more elevated, right? And that's what host modulation is about. That's about the host, right? And
Yeah.
so, not
Let's talk about, the host response. It's the most important thing when trying to achieve homeostasis. We have to spend 80% of our time figuring out what's going on with the host and the immune system. And that involves, we could go through all the risk factors that are creating a heightened immune response. And that's what these patients have. They have a hyperinflammatory immune response if they have chronic inflammation, they've got tissue loss, bone loss, periodontitis. They've been diagnosed with periodontitis, bleeding on probing, pus on probing, whatever it is, mobility. These patients have heightened inflammatory response that is it's very destructive. And the only way to really interrupt that is to treat all the causal issues. They're having, and you could even tell the patient they're having an allergic response, an allergy response to bacteria or viruses or candida, whatever's in their mouth. And we all, you and I all determine that. We're really good at determining what's going on in their mouth because we test for that. We also do, are they mouth breathing? Do they have high blood sugar? Do they have deficiencies? All of those things. Some people just have a really strong genetic component. Most of my cases are hyper responders. We call that, this is fairly new in the literature. And I have found that a lot of dental clinicians don't understand or have never heard this term hyperresponder. So let's talk about hyperresponders. For whatever reason, they're a hyperresponder, okay? They're producing way much more destructive enzyme than a nice homeostatic, response of collagenase. So collagenase is an enzyme. It's kicked out by the host cells. You've got this whole inflammatory cascade. Bottom line is, if you have way too much collagenase, if you have higher than normal levels of collagenase in your gums or anywhere in your body, you're going to get destruction. You're going to get destruction of collagen. And this is a collagen-rich environment. Everything in here holding your tooth in place is made of collagen, whether it's bone or tissue or ligament. So we have to protect the collagen around those teeth, bone, tissue, periodontal ligament. And one of the most effective ways to do that, if you're a hyperresponder, you have periodontitis, I don't care what the risk factors are, the most effective way, we're going to treat all those other risk factors, right? But the most effective tool that we have in our toolbox is to put you on low-dose doxycycline, because this is what we call host-modulated therapy. It was discovered over 30 years ago. There's over 300 published papers in peer-reviewed journals, over 300. So what we're talking about is something that's so profoundly effective in the science and in the journals at balancing out, bringing that hyperinflammatory immune response down to normal. And all it does is it takes that excess collagenase, that excess inflammation, and just brings it down to a normal level. All we're trying to do is put that host response on an even keel so that now it can heal, right?
Yeah.
These patients with chronic perio that just continue to go down and down and down, and no one ever, either they don't address the risk factors or they don't use peristat. The host response can't resolve chronic inflammation. That's really what we're talking about here. No matter how much you are good at removing bacteria, this is the thing I want people to understand. I've used a microscope in your office and our, my sister, Dr. Carroll's office. I've used salivary testing for 15 years, and I can use salivary testing and a bacterial slide with a microscope And I can't find a thing on most of my patients, a lot of them. Okay.
I've seen that.
And so now I'm doing viral testing.
Yep.
Okay. I finally found someone with a virus that all this other stuff maybe didn't show up. That's a whole nother story. I'm going to be doing research on this.
We're going to have you on for another podcast.
Know, if there's a viral
talk about
component, the host is going to respond with it's going to react with a hyperinflammatory immune response. Maybe they have an autoimmune thing going on, because oftentimes if someone has viral load or candida, that's a very vulnerable host response there. So this is our tool to just really just help your body reset the inflammatory response. It interrupts it, because once it starts, it's just this vicious cycle. It upregulates itself once it's upregulated. And once it upregulates itself, especially IL-1 or IL-6, and then it just continues to upregulate these inflammatory mediators like IL-1 and IL-6, it just leads to this whole inflammatory cascade that's so destructive. And like I said, you can be bacteria free, you can be pathogen free, and it can still be doing this thing. And that's what people don't understand, is that's why I feel like we should spend 80% of our time and energy and focus helping the immune response. And like I said, one of the most important tools for me over the years, besides going after those risk factors that have created that perfect storm, I call it, is to interrupt that inflammatory, that hyperinflammatory cascade has got to be interrupted. And I can downregulate IL-6, IL-1, and TNF alpha, these inflammatory mediators that are continuing this thing of causing this whole hyperinflammatory cascade and destructive enzymes and osteoclast cells, bone-destroyed cells. So it's this whole thing. And when I lecture, I have a slide on that. It's very complex, but it's really a beautiful slide, because it just tells the whole story. Because when we look at bacteria and candida and viruses, that's just a small little piece of the story.
And also, why are they there? I feel like a lot of times,
exactly. So that's
it's
the
next
conversation.
What came first, the chicken or the egg?
Now, and this is what the periodontal researchers have been publishing, by the way. And I feel like not enough of this information is brought into the lectures, into the conferences, is that we discovered that periodontitis is a chronic inflammatory disease. And once that inflammatory response is kicked up and it can't resolve, it can't come down, then you attract pathogens.
Right.
Then you're creating an environment that pathogens really love and can thrive in, right? And then you're going to get pockets, and it's just going to get worse. And then over time, if you've got subgingival calculus or tartar under your gums, and you've got this whole inflammatory cascade, the biofilms down there just become increasingly more toxic over time. I've written papers on this. Periodontitis is a very complex inflammatory disease, and I don't fool myself at all thinking that I've got all the answers. So I don't. And it'll break your heart, because you'll have failures even though you're doing everything right. And those are the patients that keep me up at night. But it's a smaller, it's a much smaller number of cases than it was, say, 25 years ago.
Yeah.
Or before I got an endoscope, when, doing traditional blind root planing with a laser, was that really getting me the results? No, it wasn't getting me the results. I saw some temporary results, but I didn't see what I see today.
Yeah. Well, and I think there's so many patients that come in and they're like, oh, I had a deep cleaning last year, and, they want to do it again this year. And, it's like, oh, I've had 6 of those. And you're like, well, you still have an issue. And it's like, that's not normal. There's something going on with your host response. Like, we got to, again, it's that recipe, right? We're just so focused on removing calculus, and we're not even doing that. So,
some people respond well without having to do, all of these things. But it's those really vulnerable patients that I see.
Yeah.
And a lot of them have gone to 3 different periodontists by the time they find me, and they continue to lose tissue and bone. And the periodontist may tell them, well, you look great to me, you look fine. But the patient knows, right? The patient knows that something isn't right, and they're right. Something isn't right.
Yeah.
And maybe the inflammation is sort of at a lower level, that it's not so bright that the periodontist is going, oh my gosh, we need to do root planing. A lot of the cases that come to see me, you might not have the same eye on the inflammation that I have, or that periodontist. I didn't start to recognize inflammation on the level that I do now until I had an endoscope in my hand and I could
Mm-hmm.
actually look directly at the tissue.
Mm-hmm.
That's what I'm saying. It made me so acutely aware of what was working and what wasn't working. And is that host response still, are they still in that vulnerable stage? Are they still hyperinflamed?
Mm-hmm.
Right? Are they still, even though they have perfect home care
Mm-hmm.
and no pathogens and an excellent diet and they're not smoking and they have great blood sugar, and I could go on and on. These are cases, these are the ones that just, like I said, they keep me up
Mm-hmm.
striving for more answers, really. And that's what makes perio so fun,
Yeah.
is that it's not one size fits all. But one of the greatest tools that I ever discovered, and I was periostat, was low dose
So
doxycycline. I had
Judy,
never seen tissue that healthy before.
can you,
I,
so I get this question like almost every day because I feel like people like they hear the word doxycycline and then they go home and they Google it and then they call back and they're like, that's an antibiotic. You're putting me on an antibiotic. Like I'm worried about my gut microbiome. I don't
yeah.
want to be on an antibiotic. So can you talk a little bit?
Can we talk about, yeah.
Can we just talk about
So,
that? Because I feel like that's such a conversation that needs to be had. And I mean, I get that
yes.
question all the time. So
Very important. Okay, so doxycycline comes from tetracycline, which was discovered, I think, in the 1940s in soil bacteria, and it had an antimicrobial action to it, tetracycline. So we knew it was a natural antimicrobial that came from, soil bacteria. So they took that tetracycline and they just made it better by changing some of the chemical structure so that it was more readily absorbed and had a longer effect in the body, longer lasting effect. So better tolerated, all of those things. So it comes from tetracycline. So you can't take it if you're allergic to tetracycline. But, tetracycline, when we first discovered it, of course, we're using it at a high dose to kill bacteria. And then we started using that obviously in the treatment for perio, tetracycline. And what this periodontist, his name is Dr. Golub, he's a periodontal researcher out there at Stony Brook, discovered was in his early days of being a periodontist and also a periodontal researcher was that he noticed, and this is what's great, is that he noticed that there was something else going on when he used tetracycline on his patients, his perio patients, as an antimicrobial. There was something more going on there. So he decided to dive deep into the research and figure out what was going on. Why was this so special? Why was I getting this better result with tetracycline? Why did it appear that there was an anti-inflammatory effect to it? So long story short, he published all the initial research. They ended up patenting his discovery, which was he discovered in tetracycline and doxycycline, which is a form of tetracycline, that there's an anti-inflammatory effect to it. So what he did was he took that 100 milligram dose and took it down to 20 milligrams. They actually took it all the way down to 10. And then I think they tested it 15, 20, 25, that sort of thing. And the sweet spot was 20 milligrams. So why is 20 milligrams so important? Well, you still have that anti-inflammatory effect that you want. And you don't have that antimicrobial effect of 100 milligrams. So you can take 20 milligram as an anti-inflammatory and also a regenerative medication, I might add. It also lowers blood sugar and does all these other wonderful things. But you could take that long term safely. You could take it longer than a week, or you know what I mean? If you take doxycycline 100 milligram, you're going to be killing gut bacteria. You're going to be killing because doxycycline is a broad spectrum antibiotic.
mm-hmm.
That's not something you want to be on long term. So, patients with acne have been treated with doxycycline for years. They use doxycycline in just about everything. It's one of the most prolific antibiotics that we've ever had. It's one of the greatest discoveries, really. But that you also, if you have skin diseases and you're taking 100 milligram doxycycline, you're getting that anti-inflammatory effect.
Mm-hmm.
But the nice thing about periostat, which is what that's the brand name that they ended up patenting, is 20 milligram doxycycline periostat. Yes, it's still called doxycycline. They couldn't call it something else legally because it has that chemical structure of doxycycline, exactly the same, but it's a lower dose, so it's not killing bacteria.
Mm-hmm.
And that potent anti-inflammatory effect that it has so many health benefits.
Mm-hmm.
So here we are. It was FDA approved in 97, I believe, and the research began in the 80s. Mm-hmm. And like I said, by now we've got over 300 published papers in medical and dental journals, not just dental journals, perio journals. It's been published extensively in medical. So it lowers blood sugar. It lowers, cardiovascular disease markers like HS-CRP, C-reactive protein. It lowers bad cholesterol. It's having a profound and increases good cholesterol. It's having a profound effect on the whole body. So if you have arthritis, you're going to notice positive therapeutic benefit with that. If you have rosacea, the same medication is used to treat rosacea, although it's in a 40 milligram time release called Oracea is what it's called. So your patient can either take a 40 milligram time release or they can take a 20 milligram twice a day. I like to tell them to take it on an empty stomach so that they don't have calcium in their gut at the same time, or iron, because it'll bind to calcium and iron. So I always tell them take it on an empty stomach, but twice a day is kind of hard for some people. Just know that if you take it once a day only, it's got an 18-hour half-life, so you're still getting therapeutic benefit. Although if you're a severe case, I'd much rather you take it twice a day or get the time release 40 milligram from your medical doctor. I don't know if you can prescribe 40 milligram time release. Maybe you can. But if they don't have rosacea, then it's kind of, they're treating a different disease.
Yeah.
But, here's the thing. I treat a lot of patients with insulin resistance. My patient on Friday had insulin resistance, prediabetes, we call it. That's an inflammatory disease.
Mm-hmm.
And a lot of our patients have cardiovascular disease. Maybe they've even had a stroke. Maybe they've got strong family history of Alzheimer's. Maybe they've got strong family history of all sorts of chronic inflammatory diseases. My patients generally do, because there's a strong genetic component with a lot of them. And if you start asking your patient, does anybody in the family have cancer? Does anybody in the family have diabetes, cardiovascular, all those things? And let's say that they light up yes on every single one of those things. You know that you're really dealing with a susceptible patient. Mm-hmm. A susceptible patient has this hyperinflammatory immune response that's genetic, okay? It's a strong genetic component, I call it. We can actually effectively bring that inflammation down. I mean, periostat, doxycycline, has been used to treat all sorts of things. Cancer. It's effective with Kaposi sarcoma, for crying out loud. So, wow. I mean, look into the medical research on this. If I'm going to help my host, that they've got prediabetes or diabetes, I can lower that blood sugar significantly, which also has a profound impact, not only in their mouth and their gums by lowering the inflammation in their gums and all of that. Because if they have high blood sugar, they also have really high levels of collagenase, and your smokers as well have really high collagenase. So they start taking the periostat. Not only are we lowering all that collagenase, but we're lowering their blood sugar, right? We're also lowering their blood pressure. If you've got a patient that has cardiovascular disease in the form of hypertension, right? And you want to help your patient. Let's say they have perio, and we know that pathogens involved in the mouth, oral, bad bacteria in the mouth can contribute to hypertension. And we want to bring that down by not only doing our topical, whatever it is, using the endoscope or root planing or whatever we're doing, and having them do antimicrobial rinses and that sort of thing, or laser or whatever it is you like to use. You really need to help that host with lowering the whole systemic inflammatory load going on here. We call that oral inflammatory load. How much oral inflammatory load does this patient have, and how much is it affecting the rest of the host response? So it's the inflammatory burden that we're talking about. And that's what doxycycline is so effective at giving. It gives you and the patient the upper hand on this disease and many other diseases.
Yeah.
So maybe we should talk about how long do they take it, because that's always a really common question.
One more thing, because I get this question. I think you mentioned it, but does it change the microbiome like an antibiotic?
And that's been studied. Thank you for bringing that up. It has been studied, and no, it does not change the gut. It doesn't change any of the physical biome.
It's not really acting as an antibiotic. It really at this low dose is an anti-inflammatory, and
it can't kill bacteria at 20.
Okay, it allows your body to heal. I mean, it's like taking away that collagenase so that your body now can regenerate. So, okay, so that's really, really great. And I love that they've studied that, and we can say that with confidence that it's not an antibiotic. It is not changing your microbiome. So
And Dr. Golub likes to call it non-antibiotic doxycycline.
I love that.
That's what he likes to call it, not low-dose doxycycline. He likes to call it non-antibiotic
Yeah.
doxycycline. Yeah.
Yeah. Well, and the dose matters so much. I mean, you can drink too much
Yeah.
water and you'll die, right? So I mean,
Yeah.
it's all in the dose, right? The magic is in the dose. So, and I also think that like we have had definitely some patients that have questioned or had resistance, or even their doctors have told them like, that's an antibiotic. And it's like, there's just such a lack of education, I think, out there, even in the medical community. So I think, a lot of our patients come back and have all these questions because their doctors aren't even educated on it. And so it's just, I think it's an amazing tool that we have, and it allows your body to do what it's supposed to do, which is to heal. And I think the other thing that we always have to think about too is that there's always risks and benefits to things, right? And if you are faced with full mouth extraction, or, you're going to lose a bunch of teeth, what are the risks and benefits, right, to taking doxycycline or doing a therapy, right? Because I always view it's like, do the benefits outweigh the risks? And if the benefits outweigh the risks, to me, then it's a good idea, right? But
this would be a good place to add that there's never been a negative study.
That's awesome.
There's never been a negative study.
Yeah. So what are side effects? I mean, some people, obviously, if you have an allergy to tetracycline, you aren't going to be able to take it.
Okay. So here's the things. It's 5% of people taking it may experience side effects, which is equal to placebo, by the way. So it's quite low.
Okay.
It's actually rare. It's quite rare to have any kind of reaction to it. But here's what I've noticed the most over the thousands of patients I've treated: nausea. Nausea is one, mild nausea. I tell those patients that if they do get nausea taking it, to take it with crackers or something, and it seems to improve that. If your patient takes it and they have some kind of a skin reaction, I tell them stop taking it, because that's kind of an allergy response you're having, right? Mm-hmm. More so than, let's say, a mild headache. Mild headache is one, nausea. The other thing too, I mean, the incidence is so low that I just don't see. I did have one patient in the 25 years that claimed that it caused a yeast infection, for example. We just don't see this a lot. And I said, well, that's kind of impossible, but come off of it, because you know your body. Yeah. And if it's changed the chemistry of your body and now it's causing this thing, then get off of it. But for the most part, it's very well tolerated. Mm-hmm. So I want people to not be afraid of that. Okay. Yeah. Very well tolerated, very safe. Like I said, they use it for so many different diseases. And by the way, just one other thing real quick. If you're going into therapy like root planing or perioscopy or laser surgery or whatever it is, and you start that 2-week dose before you go in and let the clinician stir up bacteria and create bacteremia, you're actually getting cardioprotection from Periostat. It's protecting your arteries from this flow of bacteria, pathogens going into your arteries and creating inflammation within the arteries and possibly causing a heart attack or a stroke, because that's what happens. Yep. And so it's cardioprotective. I really wanted to get that in there because it's so important. Yeah. So the other thing too is you can't take it if you're pregnant or nursing, right? If you're trying to get pregnant, I would say don't take it, because it has substantivity. So what's substantivity is, once you stop taking it, it's going to still stay in your system for 3 months. So let's say you take it for 6 months, it's going to continue to have a therapeutic effect for 3 more months. Okay.
But with that said, oh my gosh, if you have perio, please treat it before you get pregnant, because there's so many. I mean, literally just wait a few months, because there are so many issues when you have periodontal issues, and that can really impact your baby and the health of your pregnancy. And, there's been lots of studies that link, just issues with pregnancy and low birth weight with having active periodontal disease. So if you are thinking about having kids and babies, then you really want to take care of that periodontal issue before, if you can.
Yeah. And I've treated many women that have been trying to get pregnant for years, and they have severe perio. They find me and I'm like, well, I know why you can't get pregnant, probably, and so we get in there, do the treatment, and get all that inflammation to subside, achieve health and homeostasis, and you're pathogen free now. Now she can get pregnant, and it wasn't as hard, right? You didn't have to try as hard. So But thank you for bringing that up. It's a really good point.
Yeah.
You may, I mean, some patients report sun sensitivity, but that happens more in a higher dose, I feel, than with 20 milligram. It also may lower the effectiveness of birth control pills, birth control, hormones. Just kind of some things to think about. But when you look at this medication overall, it's so well tolerated and so safe. And like you said, risk versus benefit. If you can at least take it for the 2 weeks before you start therapy and a minimum of 2 weeks after, I'm okay with that. But the longer you take it, let's say you're a severe case and you've lost a lot of tissue and bone, because this is a regenerative medication and it works slowly over time and it takes a long time to regenerate bone, right? Especially if it's quite severe. Some patients achieve homeostasis faster. Some people achieve bone regeneration faster than others. But generally speaking, for my severe cases, minimum 6 months. Okay.
After the
and
treatment.
Even some cases that are like bone loss all the way to apex, we may go a full year, especially if they're a smoker. Right.
Yeah.
And that's the other thing you mentioned. I wanted to interject with, my job is to help the patient keep their teeth. Right. And I explain the risk versus benefit. And then I try to get them into hypnosis or whatever it's going to take to get them to cut their smoking down or eliminate it. But right now I've got a tool I can use. And so I think that clinicians should feel good about that instead of maybe spending all that time sort of lecturing, if you will, about the fact that they need to get their blood sugar down. They need to eat better. I do all that. But right now, in this moment in time, this host needs help. And even if they quit smoking, they're still going to have very high levels of collagenase for, I think it's about 3 months after they quit. And certainly if they've left if there's any calculus under their gums that's infiltrated with tar and nicotine, it's going to be really, there's so many things going sideways with smokers. But I have found that even my challenging cases, diabetics, let's say they have uncontrolled blood sugar. It's just not really, their doctor's having a hard time with it. Maybe they have diabetes 1.5 and they don't know it. I've got a patient coming in like that. Some of these patients can't control their blood sugar no matter what. Yes, we know that if we get the perio under control, the blood sugar should come down. That'll help, right? It's this whole thing. But if I can get that patient to start the non-antibiotic doxycycline, it's so profound what happens in their mouth that they never want to come off.
Yeah.
They're like, oh my gosh. And this is what happens with a lot of your patients. They're like, I'm never going to stop taking this.
I've had patients like that.
So with your severe cases, they notice this and then they're begging you for another prescription. So trust me on that. I've got many.
Yeah. Yeah, I've had a couple of patients like that too, because they just notice they've been working on these health issues with their doctor for so long, and then they get on the doxycycline and they're like, whoa, like my blood pressure is better, my blood sugar is better, and they feel better and their gums are better. And it can be really profound.
Their skin is better.
Yeah.
Women can reverse aging with it. No, I'm just kidding.
Yeah.
I can't.
We don't do that in the dental office. Yeah. We are, we're just so teeth specific, but there's these other nice benefits or side effects that are systemic.
There's a lot of positive side effects to doxycycline. There really is.
Yeah. And I think it's just
there's more positive side effects than there is.
It's important for patients listening to this to understand, this is a tool that we use, and it's not like you do it for 2 weeks and then you're done, right? Like we have to look at your risk factors, right? Because if you are one of those people who, gets the mosquito bite and it's welts up, you're going to be a hyper responder. If you're a smoker, if you have a history of heart issues or Alzheimer's or diabetes in your family, cancers in your family, you are now a higher risk patient, and we probably need to have you on it for longer to see the maximum benefit. And
and on and off, to manage long-term, because there's no cure for periodontitis.
Yeah.
So
it really is an autoimmune disease. I mean, we don't really talk about periodontal disease as autoimmune, but that's basically what it is.
It definitely is. With many of our cases, most of my cases, it's autoimmune, but I'm doing everything I can because similarly with other autoimmune diseases, you can't leave any stone unturned. You just can't. And so you're right. I reach for this as a tool to quiet and calm down that hyperinflammatory immune response. And like I said, the FDA approval is for a minimum 3 months. It's a minimum 3-month dose recommended. But, I find, and if clinicians, because I lecture all the time and I teach, and I find that clinicians are very guarded about giving their patient a medication for periodontal disease. This is a real hurdle.
Mm-hmm.
Not only do they have to talk to their patient about it, they have to talk to their dentist about it. If the dentist didn't come to my lecture, then they have to explain to the dentist what this is for. Because you're right, there's no education going on because it went generic back in 2003 or 2004, right around that time. It went generic and all the education dried up. So once it went generic, it was like, nope, there's only a couple of us out there lecturing about it, and yet this is one of the most profoundly effective, statistically significant tools in our toolbox. And I might put you on it for 6 months, have you come off, and let's say we do a 1-year reeval. And maybe you look fine at 1 year because you're not a smoker, you don't have diabetes, you've addressed all the airway issues, whatever, then you don't need to go back on. But let's say Mrs. Smith, she comes back in a year after doing 6 months, and now she looks like she's starting to get inflammation again. Okay, Mrs. Smith, did you address the apnea? Did you get the airway testing? You know what I mean? Did the risk factors get addressed? So I always look at my patients as, okay, what if, what's creating the perfect storm of inflammation, right? It's not just bacteria. Bacteria is such a small part of it.
And you could argue that you could argue that the bacteria, is a product of.
Is a symptom.
Right. So, exactly. So we still have to figure out the cause, right?
Yeah.
So, and I think it's also, you taught me about, doing labs, checking for vitamin D levels, B12, magnesium. There's also these different nutrients that are important in rebuilding bone and supporting the immune system, right? So when we have patients get labs, we're assessing those risk factors. And I've had some patients, they're like, why do you need labs? You're a dental office, and you're like, well, because we have to assess what's going on in your body. You need your building blocks so you can build bone. We need to make sure that, your vitamin D levels are good and all of that, right? It's a systemic.
I tell them that their gums are a reflection of something going on.
Absolutely.
They're not disconnected. Also, I find a lot of vitamin C deficiency. And I want to tell you that vitamin C, because a lot of people are on keto and maybe they don't consume fruit. They're also not taking vitamin C or not getting enough. That's going to profoundly affect your gum health because vitamin C is going to protect collagen, right? And vitamin C is regenerative. It's like periostat, basically. So if you want healthy gum tissue and you've got collagen through your entire body, all the connective tissue is collagen. Everything in your body is collagen. Take some vitamin C, especially for postmenopausal women like me. Vitamin C is probably one of the most important things postmenopausal women can take for bone health, for example. And that's not being talked about. And I can't tell you, it was a periodontal researcher that turned me on to actually adding that to my labs, by the way. And also, by the way, only about half of the medical doctors will actually test it. So,
it's not a common test.
I'm not always going to be getting those values back. So I just kind of automatically put my patient on. I just find that people don't eat a lot of fruits anymore. They're not getting a lot of citrus, vitamin C sources maybe. So do look at that with your chronic perio patients. I don't know. It's kind of, we're coming back to that because, years ago, even when I was fresh out of dental hygiene school, we were doing vitamin C. We were making sure they were getting enough vitamin C. I don't know if it's talked about that much lately,
they talk a lot about, high dose vitamin C, like IV therapy, right? Even they're doing that as an adjunct for cancer treatments. So, now
wonderful.
It's just, there's so many great benefits of vitamin C and it's great. It's a water soluble. So you can take pretty high doses of it. And if your body doesn't need it, you pee it out.
And B12 is deficient in suboptimal or deficient in almost every case I treat, as is vitamin D. I would say B12 and D are the two top, and then there's vitamin C and magnesium as well, but also undiagnosed thyroid issues, like that, and undiagnosed blood sugar issues.
Yeah,
right,
and hormone issues too. I think a lot of people
and hormone issues.
Hormones can cause a lot of issues with gums too.
And speaking of hormones, your postmenopausal patients need the most. They need the most help. Your postmenopausal patients, besides your smokers and your diabetics, your postmenopausal patients need your help the most. Really need to treat them with TLC and concern because they're so vulnerable for perio.
Mm-hmm.
That drop of estrogen is just creating this whole problem with connective tissue, with collagen. I can speak to that.
Mm-hmm.
Oh my gosh.
Women, yeah, it's crazy.
So, by the way, postmenopausal women, so if they have osteopenia or
Yeah.
osteoporosis
Mm-hmm.
and they have been diagnosed with that, most of them will probably be diagnosed in their lifetime being postmenopausal. I probably need to get tested. But so periostat, low dose doxycycline was studied over a 2-year period with postmenopausal women. It was a big study.
Mm-hmm.
And not only did it increase bone density in their alveolar bone, it increased bone density in the whole body. So I always tell my postmenopausal patients, look, you're getting so many benefits from this medication because it's lowering cardiovascular disease risk,
Mm-hmm.
because that's also a factor the older you get, right? So you want to protect because the gums start to get thinner the older
Mm-hmm.
you get, right?
Mm-hmm.
And they just become more susceptible to perio.
Mm-hmm.
It's a risk factor being postmenopausal. And I have many, many postmenopausal patients, many.
Yeah.
And they just want to stay on the periostat because they notice such a difference in everything, their total health. So
Mm-hmm.
anyway.
That's awesome. So Judy, so if you're a patient listening and you've been diagnosed with perio and you are looking for something more comprehensive, maybe you haven't been getting quite the healing that you want, or if you're a hygienist or a doctor listening and you want to learn more, Judy, you teach other hygienists and doctors your protocol, correct?
Yeah. So the exciting news is there is a new endoscope coming this year. The company told me that it's coming this year.
Yay.
So I want everyone to know that there is going to be a very innovative endoscope. I teach once that starts to emerge and people can actually buy it, get their hands on it. I don't work for the company, by the way. We are on our 5th endoscope now, but that's a whole nother story. This thing is going to be leaps and bounds ahead of the one that I use. So, but yeah, I teach this. I come into offices and I teach the clinicians for a couple of days. I teach the entire staff periodontal medicine, about the doxycycline, about what labs to get on your patient, all that sort of thing. So I have a comprehensive program. I leave you with a manual to, leave you with that information. I send you some training videos that I've created, that sort of thing. And you can reach me on periopeak.com. My email, my phone number is on periopeak.com. I'm on Facebook at periopeak and also on Instagram. But I do lectures. So I'll be speaking hopefully I'll be speaking at AOSH this year in Dallas, I think is where it is. And I'm just getting invited to speak more. I just did Chicago and that, so anyway, I think the timing is right for people to sort of learn this 3-pronged approach
Mm-hmm.
and really start to keep perio more in-house as far as your severe cases, but also be more preventative with your earlier cases because, hey, the earlier we can treat it, the better, right? And
Mm-hmm.
also diagnosing caries, recurrent, crown margin decay, all sorts of things you can diagnose, like we were talking about. That should all be in general practice.
Mm-hmm.
Every single operatory should have an endoscope.
Mm-hmm.
I mean, at least every hygienist should have an endoscope.
Mm-hmm.
But definitely, the doctors could even use this new technology that's coming to check their crown margins. Like after you seed a crown, for example, maybe you can clean it up then, or after you do an implant and you seed a crown, clean up that. There's so many uses for it.
Yeah.
I don't want people to think that it's just for perio because it's just another tool that we have. It's kind of like having loops and lights under the gums, and I think that it'll be routine in the next 5 to 10 years. I think it'll just be as routine as loops and lights, you know.
It makes a lot of sense.
But yeah, every practice can be doing the work that I'm doing. I tell hygienists, look, just because I've done thousands of cases, that doesn't mean that I'm something special. I learned this thing to be able to teach it and show you what's possible. That's all. I learned what's possible. And guess what? We can regenerate bone around hopeless teeth. Completely hopeless teeth. So take a look at my website. You'll see what I'm talking about. And you're giving patients another option besides either extractions or surgery or root planing. It's kind of between. It really should become standard of care, in my opinion.
Yeah.
But instead of choosing root planing, choose to do some endoscopy and, having a more comprehensive approach, if you will, for your chronic inflammation. And I teach offices to have an inflammatory program. That's what I call it. That's what I call this whole periodontal medicine approach beyond the endoscope now is to have an inflammatory program for those, chronically inflamed periodontal patients. Because even if you think you have it sort of under control, 9 times out of 10, you really don't. They still have chronic inflammation. They still have calculus under the gums, right? And if you have that, like you said, the rock in the shoe or splinter, it irritates. They are so allergic to those pathogens, first of all. And if they don't have pathogens, even just the calculus can cause cell death and inflammation. So there's antigens in there. There's enzymes in the calculus embedded in there. You can't test for that stuff right now.
Yeah.
And those are irritants.
Yep.
So get that stuff out of there.
Exactly. I mean, yeah.
And remember, your probing is probably not accurate. So you might think, oh, she responded really well to my treatment. But, I'm sorry to say that without an endoscope, you really don't know how your patient responded to therapy.
Yeah.
I hate to tell you that. People don't like to hear that, but it's true.
Yeah. Well, this has been such an insightful conversation. I love that the RP protocol is non-surgical. I love that you're addressing the host response and you're looking at systemic risk factors and you're also removing the rocks in the shoes. You're removing all the calculus out so that the body can heal. I love that you're using doxycycline and Emdogain and you really are staying on cutting edge of the current research, what's coming out. And you truly are an innovator in the field. So I just want to thank you so much for coming on. And I just feel like more people need to know about this. It's just such an amazing treatment. So thank you, Judy.
Thank you, Dr. Taylor.
All right. Well, if you're listening, make sure that you follow us, Your Mouth Matters, and make sure that you subscribe to our social media. We're on Facebook, Instagram, and TikTok. So we will catch you on the next episode. And remember, your mouth and your gums matter.